Anatomy of the knee, RAD 310, Sectional Anatomy, Bachelor of Science in Medical Imaging program, Chris Gibbons, instructor. In this media module, we're going to be going over the anatomy of the knee. The knee joint is probably the most vulnerable joint in the human body to injury. For this reason, the knee is often imaged by sectional modalities to evaluate the extent of injuries, particularly to the supporting soft tissue structures. The most common ligament injury to the knee is the anterior cruciate ligament injury, or ACL. This screen demonstrates a torn ACL on a sagittal MR image of the knee. The white arrows point to evidence of edema, while the arrow head points to the torn end of the proximal ligament. Upon completion of this media module, you should be able to 1. Describe the location of the bones that articulate to form the knee, including pertinent landmarks of each. 2. State the structures that reinforce and support the knee, including their location, origin, and insertion. 3. List the supporting soft tissues of the knee and the patellofemoral joint and their functions. 4. Cite the neurovascular structures of the knee. And then lastly, 5. Identify all pertinent anatomy of the knee on sectional images. The knee consists of two articulations. We have the femoral tibial and the patellofemoral, and both are contained within a common capsule. The femoral tibial is formed by the articulation between the femoral condyles and the tibial plateaus, which are located on the superior surface of the tibia. The patellofemoral articulation is formed by the articulation between the patellar surface on the anterior side of the distal femur and the patella itself. Since there are numerous supporting tissue structures that help stabilize the knee, it is really important to study these bony prominences that serve as attachments for these structures. Over the next few slides, you're going to be reviewing these structures. I'll have animations that will go through and highlight the structures for you in basic detail. You can also be able to pause the video as we go through the next few slides to look at some of these structures in a little bit greater detail if you wish. There will be no narration on the slides, but again, they'll be accompanied with some animations to help draw your attention to these various bony prominences and structures in this very complicated joint. The joint capsule of the knee encloses the knee joint cavity and is composed of a tough fibrous membrane. Part of the fibrous membrane is contributed by the tendons of the upper leg muscles. The anterior aspect of the capsule is formed by the junction of the tendons of the quadriceps, the vastus lateralis or lats, the vastus medialis muscles, and the patellar ligament inferiorly. The IT band helps to stabilize the anterior lateral side of the joint capsule. On the lateral side, there is a space between the capsule and the lateral tibular or collateral ligament, and the capsule is separated from the lateral meniscus. On the medial side, the capsule merges with the medial or tibial collateral ligament and attaches to the medial meniscus. And then finally, we have the posterior aspect, and posteriorly the oblique popliteal ligament and the tendon of the semimembranous muscle wrap medially to laterally to reinforce this whole capsule. The menisci of the knee are C-shaped pads of tough yet flexible fibrous connective tissue and basically function as shock absorbers to cushion the knee joint. The menisci are named by location and unique characteristics. We have the medial meniscus. It's located on the medial tibial plateau facing the lateral meniscus. The medial ends are named anterior and posterior horns and are connected to the intercondylar eminence. The outer curve and posterior horn are the thicker parts of the medial meniscus. And lastly, the medial meniscus is attached to the medial collateral ligament on its exterior. The lateral meniscus is located on the lateral tibial plateau. It's more closed in shape as compared to the medial meniscus. The medial ends are named anterior and posterior horns, just like with the medial meniscus, and are connected to the intercondylar eminence as well. The outer curve is thicker than the inner. The lateral meniscus gives rise to two ligaments from its posterior horn. We have the posterior meniscofemoral ligament, and we have the anterior meniscofemoral ligament. The internal ligaments of the knee may also be termed intercapsular because they are inside the joint capsule, yet still outside the synovial membrane. The internal ligaments are the anterior cruciate ligament, or ACL, and the posterior cruciate ligament, or PCL. The ACL originates at the anterior part of the intercondylar eminence and attaches at the posteromedial aspect of the lateral femoral condyle. The PCL originates at the posterior aspect of the intercondylar eminence to the medial surface of the medial condyle. The cruciate ligaments cross each other inside the joint. The names of these ligaments are descriptive of this unique feature. The meaning of cruciate is actually a Latin word meaning cross-shaped. So helpfully knowing the root of this word, the Latin root, helps you remember the geometric relationship of these two very important ligaments. The primary function of these internal ligaments is to provide stability for the knee joint, and each has its own role. The ACL helps to prevent the tibia from being anteriorly displaced from the femur, while the PCL protects the posterior displacement of the tibia. Both ligaments help to guard against hyperextension of the knee joint. For the next couple of minutes, we're going to watch a video about the repair of a torn ACL. I think we've often heard about ACL injuries, especially related with sports, and how this can be truly a career-ending injury for a professional or collegiate athlete. I think by seeing this video, you can see the trauma that is actually involved when you have a torn ACL and the almost medieval approach that they have to replacing a torn ACL. Though this repair can be very successful, and some athletes are able to return and almost be up to 100% after a torn ACL by going through such a procedure. But I think by watching this video, you can see the total reconstruction required for an ACL and why it's so debilitating and may take so long to come back from such an injury.
The graft that is taken from the middle third of the patella tendon is about 10 centimeters long. It incorporates a plug of bone from the lower part of the kneecap on one end and a piece of bone from the upper tibia on the other end. The defect in the patella tendon is closed. The tendon heals and eventually regains its strength. This graft can also be taken from a cadaver. This has some advantages, but also some risks. The rest of the operation is performed with the aid of the arthroscope while viewing the inside of the knee on a television monitor. The arthroscope is introduced into the knee and the joint is inspected. Any associated problems such as torn cartilage is corrected. To create a tunnel in the proper location in the tibia, a guide pin is passed through the upper tibia. It enters the joint at the spot where the ACL normally attaches to the tibia. The guide pin is over-drilled with a cannulated drill. A guide pin is now passed through the tibia tunnel and into the femur. It is drilled into the bone at the spot where the ACL normally attaches to the femur. The pin is over-drilled to the appropriate depth. A long guide pin is now passed upward through the tibial tunnel, across the joint, into the femoral tunnel, and out through the front of the thigh. This guide pin is used to pull the ACL graft through the tibial tunnel, across a joint, and into the femoral tunnel. The knee is fully flexed. Working now through a small opening in front of the knee, a guide pin is pushed into the femoral tunnel next to the graft. An interference screw is passed over the pin and screwed into the femoral tunnel. This secures the upper end of the graft in the femoral tunnel. The knee is now extended and the graft is pulled tightly. As tension is applied to the graft, a second interference screw is screwed into the tibial tunnel. This locks into place the lower end of the graft within the tibial tunnel. The screws securely hold the new ACL in place until the bone plugs heal in place. The knee is now stable and motion can begin immediately. In fact, a continuous passive motion machine, or CPM, is used to slowly move the knee about 23 hours a day. This early and continuous motion is very important to decrease knee pain, to quickly regain knee motion, and to avoid problems with the kneecap.
The previous video and the slide before that had to deal with the internal ligaments of the knee, which may be also referred to as intercapsular ligaments because, again, they're located inside the joint capsule. Now let's switch our attention to the external ligaments of the knee, which may be referred to as extracapsular, again, because of their location outside of the joint capsule. The external ligaments function to fortify the joint capsule. These ligaments include the collateral ligaments. There are two of them, and they reinforce the sides of the joint capsule. The two collaterals are the lateral or fibular collateral ligament. It has a rope-like shape, separate from the fibrous capsule by a bursa that's underneath it. And then the superior attachment is the lateral femoral epicondyle. The inferior attachment is the fibular head on the lateral surface. The other collateral is the medial or tibial collateral ligament. This one is broad and flat in shape. Its superior attachment is the medial femoral epicondyle, and its inferior attachment is the medial tibia. Our next ligament is the patellar ligament, which supports the anterior aspect of the joint capsule. The superior attachment of this ligament is the superior margins of the patellar apex, and the inferior attachment is the tibial tuberosity. Next, we go on to the patellar retinacula, and there are two of these ligaments. They help to reinforce the anterior joint capsule. We have the medial portion. It's comprised primarily of fibers from the vastus medialis muscle. Its inferior attachment is the medial tibia. And then the second of the two patellar retinacula ligaments is the lateral portion, which is comprised of fibers from the vastus lateralis, rectus femoris, and IT band. And its inferior attachment is the tibial tuberosity on the lateral side. And moving on to our next ligament, we have the oblique popliteal, which strengthens the middle of the posterior joint capsule. It is a continuation of the tendon of the semimembranous muscle. It extends laterally to attach to the intercondylar line on the anterior and proximal femur. And our last ligament is the arcuate popliteal, and that fortifies the inferior lateral aspect of the posterior joint capsule. It extends superiorly from the fibular head, passes over the posterior intercondylar area, and the inferior attachment is the lateral femoral condyle on the posterior surface. So again, to summarize, the external ligaments of the knee are the collaterals. There are two of them. You have the lateral or fibular, and then you have the medial or might be called tibial. We have the patellar ligaments. We have the patellar retinacula ligaments, which include two. You have the medial portion and the lateral portion. We have the oblique popliteal, and then lastly, the arcuate popliteal. In the knee joint, there are more than 10 bursa that can be found functioning to protect and support the muscles. Remember that a bursa is a fluid-filled sac that helps tendons glide over bones and other tendons. Generally, the normal bursa are not visible in sectional images of the knee, but sectional imaging can be useful in demonstrating the inflamed bursa or bursitis. Because of this reason, it's very useful for imaging professionals to know the location of the 6 major bursa of the knee joint. The major bursa are as follows. We have the suprapatellar, located between the quadricep tendons and the distal femur. We have the prepatellar, located just below the skin surface on the anterior patella. We have the infrapatellar. We have a superficial one found over the patellar ligament between the skin and the tibial tuberosity. And then we have the deep one, which lies beneath the patellar ligament anteriorly and slightly superior to the tibial tuberosity. We have the gastrocnemius, and there are two of those. We have the lateral one, located between the lateral head of the gastrocnemius muscle and the lateral femoral condyle. And then we have the medial, which is located between the medial head of the gastrocnemius muscle and the medial femoral condyle. We have the semimembranous, which is situated between the medial head of the gastrocnemius muscle and the semimembranous tendon. And then lastly, we have the popliteus, which is tucked between the popliteus tendon and the lateral tibial condyle. There are many neurovascular structures that pass through the knee. These structures pass through the popliteal fossa as they continue from the hip and upper leg through the knee into the lower leg and foot. The popliteal fossa is the posterior diamond-shaped area of the knee joint. The upper borders are formed by tendons of the hamstring muscles, while the lower borders are formed by the medial and lateral heads of the gastrocnemius muscle. Some of the important innervations of the knee and lower leg are the tibial nerve, the common fibular nerve, both of which are branches of the sciatic nerve and descend on the corresponding sides. And then important vessels of the knee are the popliteal artery, which is a continuation of the femoral artery, the popliteal vein, which runs adjacent to the popliteal artery in the popliteal fossa, the anterior tibial artery, and the posterior tibial artery. And lastly, we have the peroneal artery, or also called the fibular artery. This CT axial image was obtained at the level of the proximal tibular-fibular articulation. Look at the locator diagram on the right to see the level of this particular sectional image. This image was viewed in the bone window, which is the optimum density and contrast to demonstrate fine bony detail. Note some of the labels in this image: the tibular-fibular articulation, the tibia, and the fibula. The round midline structure that is slightly brighter than the surrounding muscle is the popliteal artery. This is an axial image, and it is a T1 weighted MR image through the femoral condyles of the knee joint, as indicated by the locator diagram on the right of the image. In this examination, the patient's lower limb was laterally rotated, but we are still able to locate and identify the pertinent knee anatomy demonstrated in this particular image. Let's begin with the bony structures. In the upper center of the image, the medial and lateral femoral condyles can be located, including the intercondylar fossa on the posterior aspect. The anterior aspect of the femur features the indentation that is the patellar surface. The patellar surface and the articular space is filled with the higher signal intensity infrapatellar fat pad. The most superior bony anatomy is the distal patella near the apex. However, note the dark outline on its anterior aspect. This is the patellar ligament that attaches to the tibial tuberosity. Now it's time to locate and identify some of the muscles found at this level of the knee joint. Look at the most lateral aspect to locate the bicep femoris muscle. The two heads of the gastrocnemius muscle, or calf muscle, are adjacent to the respective femoral condyles. The only other muscle to identify is the very distal end of the sartorius, located just posterior to the exterior surface of the medial condyle of the femur. The tendon of the gracilis muscle is the dark circle located medial to the sartorius muscle, while the semimembranous tendon is seen on the opposite side. On the superficial, posterior, and medial aspects, the tendon for the semitendinous muscle is demonstrated as a small dark circle. The popliteal artery is seen between the heads of the gastrocnemius muscle and demonstrates as a low signal circle ringed by a slightly higher signal intensity halo. Finally, the anterior cruciate ligament is the high-intensity band in the intercondylar fossa, curving to attach to the medial surface of the lateral femoral condyle. This is an axial CT scan obtained at the level of the proximal tibio-fibular articulation. Besides the bony anatomy of the tibia and fibula, the only structure clearly visible is the popliteal artery, located just posterior to the tibia. This MR image was obtained at the level of the knee joint. Study the locator diagram on the left to become more oriented with this particular level. Let's begin by identifying the structures at the uppermost aspect of the knee joint. The superficial dark line in the center of the anterior aspect is the patellar ligament. Just deep to that lays an area of high signal intensity, which is the infrapatellar fat pad. Appearing on the border of the inferior aspect of the fat pad is a dark oblique line, which is actually the transverse ligament that connects the anterior borders of the menisci. At the opposite side of what is still visible of the femoral condyles is part of the posterior cruciate ligament. The muscle just posterior to the posterior cruciate ligament is the popliteus. Keep your focus on the midline structures and look more posterior to the popliteus muscle. The circular structures seen here are the popliteal vessels and the tibial nerve. The popliteal vessels demonstrate with a slightly higher signal intensity. These neurovascular structures are bordered by the medial and lateral heads of the gastrocnemius muscles and the plantaris muscle. The medial head of the gastrocnemius is on the right of the neurovascular structures. The lateral head is posterior to it, and the plantaris muscle is on the left. Superficial to the plantaris muscles are two darker circular structures. The more anterior circle is the bicep femoris tendon, and the common peroneal nerve or fibular nerve is just posterior to that. Anterior to the bicep femoris tendon on the lateral aspect of the lateral femoral condyle is the lateral or fibular collateral ligament, which demonstrates as a dark line. Follow that dark line toward the anterior aspect of the knee and you will see the IT band. On the medial superficial aspect of the knee, the medial or tibial collateral ligament also shows up as a dark line adjacent to the condyle. The darker circular structure, posterior and slightly more superficial to the ligament, is the greater saphenous vein. This MR image is about the level of the mid-coronal plane of the knee joint. The femur is the proximal bone and the tibia is the distal bone, with the medial and lateral condyles of both bones easily identifiable in this image. Focus on the top of the image and let's identify those muscles that are part of the distal thigh, which are the vastus lateralis muscles and the vastus medialis muscles, respectively. The IT band is the dark line on the lateral side. Stay focused on the lateral side and shift your focus to the bottom of the image. Note the location of the tibialis anterior muscle. Finally, we have to locate and identify the supporting soft tissue structures of this image. On the medial side, a dark wedge-shaped medial meniscus is seen, and then also we have a dark line, more superficial to the meniscus, is the medial patellar retinaculum.